Good morning, TCSN Live. Adam Prine here, and it's Medicare for All Monday. We took the last couple of weeks off because home and family has to always come first. We always have to remind ourselves of that because we can get carried away with the movement, which is a good thing, but we have to take care of the kids too. Today I have Valdez Bravo and I have Cindy Jacobs with us. Valdez Bravo is from HCAO, Healthcare for All Oregon. He is the vice president over there, so I'm super excited to have him on. And we got Cindy Jacobs from Whole Washington, representing that state, who's leading the way in Medicare for All in this whole country here. So thank you both for coming on.
Thank you for having me, Adam. It's a pleasure to be here.
Yeah, likewise here.
No problem. So Valdez, what's going on in Oregon today or recently with the healthcare movement?
Well, we're really excited. Healthcare for All Oregon is been the organization here in Oregon that's pushing for a publicly funded universal healthcare system here in Oregon. And there is a Senate bill 770 A4, if you talk about the amendment, that kind of carries the same name as our organization. It's kind of like the Healthcare for All Oregon bill. And it was introduced by Senator James Manning, who's down in Eugene. And essentially what this bill would do would form a board that would come together of experts and analysts, healthcare professionals, activists, people from the community to weigh in and shape what that would look like here in Oregon. So its charge is basically to create, develop, implement, and then provide oversight of a publicly funded universal healthcare system here in Oregon. And so it doesn't, pull the lever and, create a single payer system here in Oregon like that. It creates this board that would be charged with doing that. But we're excited because with the work that's happening at the national level, it seems like this would coincide nicely with there's a 2-year timeline on that. And this would put some kind of infrastructure in place to have a kind of a thoughtful approach to how we would do that here in Oregon. So right now it's at Ways and Means. There's a little bit of money attached to this. We want to make sure that it's funded and the people that would be working on this board would actually receive a little bit of a stipend, which is kind of unusual for a group like this, but they felt that was necessary to get a really inclusive group. So
wait, what was that last little part you said? The people involved with what?
The people on the board, there would be a little bit of money attached as a stipend, just to make sure that it's not just people of means that can participate, that anyone that has a perspective that needs to weigh in on this would be able to participate. So just breaking down some of those economic barriers to participating in government, good government kind of stuff. But we're really excited about it, and we'll see where it goes next.
Wonderful. Okay, so we voted on that a couple weeks back. That passed. Now we just wait for the summer to go through before we move anything forward with that. Is that how that's working? I'm not familiar.
Well, it's at Ways and Means right now, and the session actually, only goes until, it only has about like another month or so. So it's Ways and Means. It just needs to get funded there, and then it would have to get sent over to the House and passed. But we're really optimistic about it.
Okay, and funding is like we've got the funding under control. Who's funding it?
It would be, well, it has to come from Ways and Means, and there's a price tag of around like $900,000 for this to go along with this, and so basically they're jockeying for money down there in the legislature to get that done, and people are continuing to apply pressure from Healthcare for All Oregon and in our circles, just on their legislators and everything, to make sure it maintains visibility as a high priority.
Okay, and then what could people do sitting at home today to is there anybody they could call? Is there anything personal that we could do as just regular people to push that forward?
Yeah, I mean, the two things I would ask, or three things really. One would be go to hcao.org. Healthcare for All Oregon's website is hcao.org. And there's a statement of support, and you can sign a statement of support because we're always amassing signatures and showing the public backing for Healthcare for All here in Oregon. Two, there is a membership link. You want to become an ongoing member and staying part of the movement and supporting the movement that way. But directly for this, I would say, contact your state senator. I'd start with your state senator and then your state rep, and just email them a short message about why single payer type system, Medicare for All, or a publicly funded system here in Oregon is important to you, if you have a story to share about why that is, that would be great too. You know, in politics, data is good, but stories and things that win over the heart seem to carry the day. So maybe just a short blurb about why it's important to you and asking them to fund SB 770.
Wonderful. So you said signatures are a big thing. So you can't do that on, if you go online and go to the HCAO website, does that work, or do we have to actually have signatures right now?
No, you don't need signatures right now, because we're not pushing for anything on the ballot right now. But just in terms of at hcao.org, we have a little button that says statement of support, and you can fill that out, and it's something that we can always go to and pull and say, hey, look at all the support we have.
Nice. Wonderful. Awesome. You guys are doing it. All right, I'm going to move over here to you, Cindy. What's going on in Washington? I know you guys are doing it too.
We are. We've been at it for a while, and it's a long process. So we're in it for the long term. First of all, we're obviously very proud in Washington to have Pramila Jayapal, who sponsored an amazing universal health care coverage bill at the federal level, which obviously would be the ideal solution. So we fully support that. We've endorsed that, and we encourage everyone to contact their federal congressional representatives and senators and urge them in the strongest possible terms to support that bill and the companion that would be in the Senate. So that's what's going on on the federal level, and we are obviously watching that. On the state level, we actually had a Washington-specific study done by a healthcare economist who's got a national reputation. He's actually reviewed healthcare funding on the national basis as well for the various versions of universal health care that have preceded Representative Jayapal's bill. His name is Gerald Friedman. He's from the University of Massachusetts. And he did a Washington-specific study that gave us the basis for the funding needs for a universal healthcare system in Washington. We developed an initiative to the people that we gathered signatures for last year, and it was the full meal deal. It would establish a universal healthcare coverage system in Washington. It had a complete funding package, and it set up a trust that would be administered by the State Department of Health, specifically the Healthcare Authority. So it folds into an existing structure, and it would have a board. The trust would have a board. There would be 3 advisory committees split basically into the subject matter areas of finance, representation for providers, and representation for patients and consumers. And they would come together and set up the package, which had there was a minimum level of coverage. Dental and vision, of course, were included. Would negotiate with providers for rates, including pharmaceutical companies, so their bargaining power with pharmaceutical companies in terms of the whole state of Washington, right? If you want to sell your prescription drugs in this state, you have to negotiate with us over the prices. Right. So we ended up with a complete package. Of course, we have not a whole lot of money. So the initiative process in Washington requires a certain number of signatures, which is a practical matter, are almost impossible to get if you do not have paid signature gatherers, which we did not. So we did not get enough signatures. Right. Undeterred, we turned our initiative into a bill that was actually picked up by one of our state senators, actually 3 of our state senators. We took the initiative. We actually met with the 2 Washington state agencies that would be collecting part of the funding vehicle. So part of the funding would be a payroll tax for employers at 8.5%, which is a whole lot less than most of them pay now. A 2% personal health assessment on the employees' wages, which again is a whole lot less than most people are paying now. Plus a 2% assessment on sole proprietors as an excise tax. We also had a capital gains tax, and then there would be a modest premium not to exceed $200 a month. Everyone is covered. There are no premiums at all for people below certain income levels and for anyone under the age of 19. So we met with the Employment Security Department and the Department of Revenue, who would be the two Washington state agencies collecting the state collected portion of it. They helped us tweak the language so that it could be folded fairly easily into their existing structure. They were actually quite supportive. We were very, very pleasantly, I guess, surprised. So we tweaked our initiative that way, turned it into a bill. It got introduced by 3 senators, and it died in committee. This did not surprise us.
Okay.
There's a lot of opposition to this, as you might imagine.
Yeah.
Yeah. And our bill was, in fact, it wasn't going to study anything. We already had the study, and we had, Dr. Friedman's full, very detailed summary. This would have actually established a program within about a 2-year ramp-up period. So our bill died in committee because this was the first year of a biennium here in the Washington legislature. It's not dead, it's just sleeping.
Okay.
So it doesn't have to be reintroduced. It will be back in next session. Our session ended in April.
Okay.
So there's some hope that if we can get some pressure on these committee chairs to let it have a hearing and get it out of committee, that would help. But in belt and suspenders fashion, we are planning to reintroduce an initiative. And we obviously, because we have no money, we went ahead and we filed an initiative to the people, but we don't have the money for signature gatherers. So what we're doing with that one is we're going to poll. We're going to poll on the ballot summary, and what we're hoping is that we get enough support from the polling so that we might get enough money to actually gather signatures when we refile as either an initiative to the legislature or an initiative to the people. So right now, what we need people to do is contact, and Valdez, you said this, contact your state rep, your state
Right.
senator, and say, we need this. We don't need to study it anymore.
Right. Okay.
It's a done deal. We have a study. We know this will save $9 billion a year in Washington. Yeah, $9 billion, and cover. And ours, like Representative Jayapal's federal bill, removes the ability of for-profit insurers to participate as now, and all they would be third-party administrators under this system. Because the entire package would be administered by the healthcare authority. So existing healthcare insurers could sign up to be third-party administrators, similar to what Medicare fiscal intermediaries look like now, only they would not be allowed to be for profit, which unfortunately is still allowed in Medicare, which is one of the problems with Medicare.
Okay. So this is,
yeah.
Let me stop you here for a second. So this third-party thing, I don't know much about this stuff. So can you explain, and our viewers might not either, can you explain to us what you're saying with this?
Sure. So in a universal single payer system, the payer is, in this case, the payer would be the state of Washington. All the money would come into the healthcare authority. That doesn't mean that somebody sits in Olympia and administers all the claims that come in.
Right.
They have to contract out. Medicare does this, Medicaid does this. So they have to contract out with entities that will actually process the claims using the guidelines that have been set up by the healthcare authority. So this is where, and an existing healthcare insurer does this all the time anyway. So they would have to switch their focus. For one thing, they could no longer do it as a for-profit.
Okay.
But you would still need, the healthcare authority would still need to contract with as a practical matter, probably several entities to help handle the claims. This happens in workers' comp. It's very common. So that's what their role would change to. In our bill actually includes provisions for displaced workers, because
Nice.
this is going to upset a certain market,
Right.
which is, and there are people working there, and they should be able to continue working, but
Right.
there are going to be plenty of claims to be processed. So,
But it would stipulate that it had to be a not-for-profit
yes,
third-party administrator. That's pretty cool.
Yeah. Well, one of the problems with profit in this is, even if you have a fiscal intermediary under Medicare, they behave like an insurer, and there's a concept called a loss ratio that they get themselves all exercised about. If they're not for profit and they have a loss ratio of 1, they're happy because they're meeting their costs. If they're for profit, they're not happy with a loss ratio of 1. They want it way under 1, and that's why they deny claims.
Yeah.
So, yeah, the insurance model is a terrible model for healthcare, because everybody uses it. It's not like auto insurance, where there's a reasonable expectation that you'll never need to use it,
Right.
or never need to use it, in terms of large claims. But everybody uses healthcare, so the insurance model is terrible.
It's like when we say in healthcare we need to put people over profits or anything aspect of government. But yeah, whether it's it all looks different, whether it's the pharmacy or medical device industry or at the hospital level. But yeah, the insurance is probably some of the most notorious cases, right?
It's a terrible model. Healthcare should be infrastructure, not a commodity. So we right now we just need people to hammer on both their state and federal reps and senators that we really need this. You can go to wholewashington.org, and you can donate to us. We really need any funding that we can get. And then you can also sign up to be a volunteer for Whole Washington, because when we do get to the initiative phase, we are going to need people to go out and get signatures.
Right. Now, you guys, last time around, I did hear about this, and you guys got close to getting the signatures, or you guys fell short, but you did.
Yeah, we were about halfway to where we needed to be. It's really almost impossible unless you have paid signature gatherers.
So how many signature gatherers have you guys made an estimate how many you're going to need to achieve this goal?
Yeah, there's actually the hard threshold is 250,000. And that's 250,000 ballot signatures. So as a practical matter, because some of them get disqualified,
right?
We have, our goal is to get 325,000 signatures.
Okay. And but how many people do you think you would need to gather signatures to do that? 50?
That's a great question. In part, it depends on how many signatures people pledge together per person and how realistic that is. We haven't come up with a hard goal, because we're hoping to actually be able to hire a few if we can get enough donations. So right now, our signature gatherers are all volunteer.
Right. Well, we got to pay them. I mean, it's just the way it is. We can get 40 hours a week out of them if we pay them. And hey, we need more jobs in this state anyway. So the goals right now for you guys is to get the people to volunteer, and let's raise some funds up for you so we can get people out there getting the signatures. Wonderful. So we got two different things going on here. Now in Oregon, let's go back to you, Valdez. What are we going to be doing for this month, for this summer, to move this forward?
For this summer, we're just continuing to apply, pressure to Ways and Means to fund SB 770, so it can, get put together and formulated, and come together and get the members selected and everything. But right now, like I said, it's gotta make it out of the Senate Ways and Means Committee. So that's the pressure right now, is just telling our legislators to voice their support for that. Obviously, we live in a budget constrained environment. We just had a big bill pass here for student success, which everyone's really excited about. And we're hoping that because that is bringing in some funding, that wasn't going to be there because it just revisited the way we're doing the taxation down here. Then maybe there will be a little bit of money left over here and there that normally would have been all just dedicated towards K through 12 education. Now that there's a novel funding source for K through 12, maybe some of that money can go to other places like this Healthcare for All Oregon board that we're putting together. So really just putting pressure on them to support that and get it out of ways and means to fund it.
So we're relying on our representatives down here right now. We can't go out there and
we always are.
Oh, that's scary. So who do you know, can you tell us some of the people that are for, some of the people that aren't for? Like, where's Kate Brown on this?
No, I think she's supportive of it. I mean, okay, so like I serve on a local community college board, right? And
okay, yes.
At Portland Community College. And, when you go to the legislature, everybody is 100% behind you. Who's not for community college education? We're going to, we support you all the way. And then when you go to ask them to, commit to funding, so you don't have to raise tuition and cut jobs and stuff like that to faculty and programs. There's the, we'll see, and there's, give it the old college try, no pun intended. And I feel like it's kind of similar, I don't really know of a lot of opposition to this. Actually, that's something, as you all are probably aware of, that although single payer and universal healthcare tends to get branded as, a socialist style approach to healthcare and all those kind of things that they used to try to fearmonger with folks that, trying to get them not to be voting or in favor of something that would be in their own best interest. This is actually quite a lot of bipartisan support for this kind of, because people know, whether you're a progressive or, liberal, Democrat, whatever.
Conservative. Like, seriously.
Yeah.
Well, I don't know about the representatives, but when I'm out on the town and I'm, talking to people and stopping people and talking to people, and I break it down, a lot of times when it's explained the right way, conservatives are like, oh, well, yeah.
Totally.
One of the biggest things is the socialist scare. And I always explain to people, and I don't know how this is working, and you too, Cindy, I would like to ask this. We're still, in both these states, you guys are still talking about keeping healthcare private, right? Like the hospitals, the doctors. You're just talking about eliminating, or are you guys talking about doing government healthcare? I'm confused. I want to clarify.
No. Our initiative, just the healthcare providers stay the way they are.
Right.
They just get paid. They get paid by money that's in the trust with the healthcare authority. That's the only source of their payment. That's who negotiates the payment rates. That's who has bargaining power.
And it's the payment being in the form of the insurance companies?
No, the payment. So what would happen is patient goes to the doctor under our setup. The patient goes to the doctor. The doctor sends the bill essentially into. So this would have the process would have to be developed by the board. But the basic way it would work is the physician sends the bill to the healthcare authority. The healthcare authority then farms it out to.
Okay, let me ask you a question real quick. So right now, the physician sends the bill to the insurance company? Correct. Okay, so they're just going to be sending the bill to the government instead of sending the bill to the private insurance company.
Right, and then the healthcare authority would farm out that processing work to the fiscal intermediaries, which look a lot like healthcare insurance companies because they pay claims, and then they would issue the payment to the provider. But it's only one. It's one stop for each provider.
Single payer. That's the whole single payer thing. Okay, but then the doctor is still working under a private hospital for a private private corporation and all that, right? So that's going to open up a lot of competition, I would see. Because how many people, do you know a number of how many people are uninsured in Washington right now?
We have about 500,000 people in the state who are uninsured.
So 500,000 people will now become new customers
Correct.
to all these hospitals and doctors. So that in a capitalist world,
they already are. They're just going to the ER.
they're going, oh yeah, and then we're, oh yeah, that's terrible, and we're still paying. Yeah, that's not good at all. So then that's where people are like, the only thing I see there is maybe the doctors and the hospitals will get a little bit less money for things, but they're going to have more customers.
That is their concern. I can tell you right now, that is their concern. They're freaked out because they don't feel like they get enough reimbursement for Medicare. What the problem is, I think that they have tunnel vision about that. It's because the system is so fragmented that the way they have to negotiate rates with private payers drives up the cost, because they know they're not going to get their actual costs met. And so they drive up their rates so that they can recover enough to pay their costs. You know, and there's also a big difference between for-profit hospital systems and nonprofit hospital systems.
Oh yeah.
Profit hospital systems just need to cover their costs. You know, our bill does not tackle the whole issue of for-profit hospitals, which I have a personal problem with. But the entire pricing system and negotiating with private payers is so fragmented right now that I believe that's a large part of what has led to the ridiculous inflation of hospital and healthcare provider charges. Those are way above. If they got paid their actual costs, they wouldn't need to do that.
And you have all these middlemen. Everyone needs to make their cut in their process. And then because of that, because of all these layers, there's like no price transparency. So, you know, hospital A, hospital B, hospital C, you get an appendectomy at any one of these, and it's going to be, one might be 11,000, one might be 60,000, and it just but you don't know it, of course, until the bill shows up. So it's like, to Cindy's point, like, we actually don't have a healthcare system. You know, everyone has a national health system. You know, Canada has their national, you know, health program with like a national insurance. Here in America, like you said, we got county health, we got state hospitals, we got federal, we got, you know, VA, we got IHS. We got Medicare, Medicaid, we got for-profit, not-for-profit. I mean, Doc in a Box, Zoom Care. I mean, it just, and then there's all these insurance companies. It's a mess. It's funny. When I was studying my master's for healthcare administration, we looked at this chart that actually the Republicans had put together to try to show the complexity of, you know, basically how futile it was for the Affordable Care Act to go into place, because it was showing all this placeholder, the stakeholders and everything. And it's actually quite illustrative of the problem that exists, you know, in America being so fragmented. And one thing I like to try to simplify it down for folks at home that are watching, that are like maybe supportive of this, but they're a little scared because they're like, okay, well, I'm on Medicare. I like my Medicare. I don't want it to go away. Or, you know, I don't want the government to be, you know, delivering my healthcare. Just to kind of just take a step back, you know, so here, you know, the way we look at it is the FIDP model. Right now, there, you know, when you look at healthcare, there's someone financing it, there's somebody insuring it, there's somebody delivering the care, and then there's somebody paying for it. And so here in the US, you know, who's financing it? Well, sometimes you have people that don't even have insurance. You have people that are paying it for themselves all on their own, particularly like a small business owner or something. But most of us, it's a combination with their employer, right? Which sucks, because that means that my employer is the one that's determining what kind of care I can get, what doctor I can see. So people say, I don't want the government telling me what kind of, who I can see and who I can't see. Well, most places your employer is already doing that. But anyway, so your employer and you kind of pick up the bill for the, you know, buying the healthcare. Your insurer is the one that's actually, you know, facilitating that. And then you go to the doctor. And you can go, you know, sometimes you have a lot of choice, sometimes you don't. You know, you have to go to in-network based on what your employer usually says. But you go to and they're the deliverer. And then after the care is rendered, you know, you'll get the bill. This is not a bill because it goes to your insurance, but then you're stuck with part of it, usually with a copay or, you know, a deductible, some kind of, which, you know, even if you have access to healthcare, might be that might be a break the bank for you because, you know, it might be so high. So anyway, so FIDP, all fragmented, all different stakeholders. And to Cindy's point, sometimes at that insurer level, or even at the deliverer level, there could be different layers in there. So you might have 4, 5, 6, 7 people involved in your care, which makes it extremely wasteful. And it's one of the reasons why, you know, it's 18.5% of our GDP is going towards healthcare right now. Now, if you look at England, just to show the different models. So England is pretty much, you know, national health system, government run, government delivered healthcare. So the financer is the, you know, the Brit who's, you know, paying their taxes or whatever. But then the insurer, the deliverer, and the payer is all the government. So you get some efficiency there by cutting that out. And, you know, the government is charged with having your back and making sure you get the care you need. And then in Canada, it's a slightly different model where it's kind of looks like the US. If you go up there, you get different hospital systems, different healthcare systems. But because every Canadian has that national health insurance, you can present to hospital A, hospital B, hospital C, and they're going to honor it. My wife is from Canada. We go up there all the time. I'm always asking my Canadian relatives and friends about, you know, their care, because I'm always just like, you know, the grass is greener up here. And it's nice because, you know, so if you take the payment side out of it, and if you're like, okay, I can go to Burnaby Hospital, or I can go to Vancouver General, or I can go to this hospital to have my baby or to have my procedure done, and it's all going to be the same to you because of your national health insurance. And the only thing that really is the differentiator is things that are in your interest. What's closest to me, what has the services I need, where is the doc that I have a good rapport with, what has the best outcomes, what has the best quality in terms of environment of care.
Right. So here's the question. So that is competition. Are the hospitals now?
Exactly.
Because right now, like you said,
the right things, not price point, but actual things that matter to the patient.
Exactly. So like right now they say, I'm on healthcare. I mean, I'm on the OHP plan, and other people for private, their doctor, their company they work for tells them who they can go to. You can't go out there and say, like, when you go to the store, I want this brand because I like it better. You can't do that. Nobody can do that right now. And when this changes, is that going to be the new thing? Now I can go to any, like, because right now I can't go to any doctor. If we get healthcare for all in Oregon, can I choose any of the doctors that I want?
That would be our intent. That would be the universal healthcare system. Is everything is going to be in network to your state, you know, publicly funded insurance program. I don't know, Cindy, if that's what you guys are looking at there. But I like to remind people.
That is why I'm saying the conservatives love it.
English model. The English model would be like, if we were, you know, we say Medicare for all. If we were saying VA for all,
yes,
that would be like England.
Yeah, exactly.
Right.
But we're not doing that.
And of course, our bill, we can't do anything with the VA because that's federal.
Right.
We could get the Medicare money for Washington residents who are on Medicare into the trust if we get a federal waiver. But otherwise, those folks would just continue on Medicare. They could elect the trust as a supplemental plan. And if they would like, we have a provision to reimburse their Medicare premiums if they just want to sign up, if they're at less than 200% of the federal poverty level. Our model is basically the Canadian model. So it's one payer, but the providers remain as they are. And the big difference is it's any provider. There is no network. It's just if you're a provider in the state of Washington, you have to negotiate rates with the healthcare authority, or you're just going to get paid what they say. And they're just, and of course the healthcare authority, the way we set it up does not contemplate having the healthcare authority individually negotiate rates the way private insurers do now, which would reduce a lot of the fragmentation. In fact, the administrative efficiencies alone of this are a big chunk of the savings in Dr. Friedman's study. So yeah, our model is basically the Canadian model, tackling the healthcare provider system itself. In other words, moving towards VA for all. That's a huge step. Not that, and ours is a huge enough step.
Right.
Yeah.
So
and I don't
the
feel like
thing is, here's what I get with this is
Yeah.
the VA. I do talk to people, and there are many people out there that are saying yes, they want to go the full 9 yards and go VA for all, that type of thing. Personally, I don't think that America's ready for that. And personally, I don't even know if I'm ready for that. But that's just because I probably would be if I knew more about it. Because I wasn't ready for Medicare for all until I learned what it really was. And when I got explained, the more I learned about Medicare for all, I was like, oh, this is wonderful. It's socialism, sure, if you want to talk about taking care of the sick people, but it's also changing the system so it's free market, and we have competition opening up. We're eliminating this mandatory go to this hospital. And so I think everyone's going to be fighting to get their customers. That's how I think it's going.
Exactly. I mean, that's the thing. I think that good or bad, capitalism is so firmly woven into the fabric of the U.S. and our mindset, just the way we approach everything, that I don't think that we're gonna probably fully get to a full-on system anytime soon. But I do feel like Adam, to your point, like this is kind of like the best of both worlds. People have the choice, and they have the market competition is promoted in the terms of you're competing on quality and not like who you cut out of the system, who you deny. How quickly you discharge somebody. I mean, the thing, if you look at Representative Jayapal's bill, like, it's great. It keeps all the best parts of the Affordable Care Act. I mean, I wish the Affordable Care Act had gone farther. Obviously, a lot of us in the movement do. But the thing that was and I think irreversibly changed, which was a great thing, which is because I work at the VA, and I've worked in healthcare since I was pretty much 18 when I joined the Army. And when they introduced through that this notion of volume, or value. Before it was all volume, and I could refer to myself and come back and see me in 2 weeks, come back to see me in 2 weeks, come back and see me in 2 weeks.
Yeah.
The patient is complying. My doctor needs to see me, and you're coming back, and they're charging you.
Right. Yes.
Procedures you may not need and all that, right?
Yes.
And with the Affordable Care Act, the beautiful thing about that was it really went from volume to value-based care. And so if you get readmitted too soon, Medicare, we're not going to pay you. If you have this many outcomes, we're not going to pay you. All these quality measures to make sure they're taking care of the patient. So, and Pramila Jayapal's bill, maintains that in terms of this. Okay, I've got options. I can go places, but it really is the true north is value and what's best for the patient. And everybody has the access to care, and just as a word, sometimes you have to watch your local elected representatives, because sometimes they, maybe they mean well, but like, I don't want everyone to have access to insurance. I want people to have access to care. And
Care. Yeah.
if I have access to insurance, well, that insurance might be $2,000 a month, and I have access. I can't afford it. It's like if I go downtown, I see some fancy diamond necklace in a window at a storefront, I have access to it.
Yes, right.
So
access right there always worries me, and a lot of people don't even know that they're doing it. Like, especially with these new candidates that are running for Congress and stuff, the new Progressive Caucus movement, they come out and they're like, access. I'm like, no, don't say access. Free range chickens is an example. Free range chickens have access to the outside, but their doors are like required to be a couple feet, and they don't have to go outside their entire life. They just have to have the access to go out there.
Exactly.
We want cage-free chickens.
Right.
Just like the wording stuff, politics. And then let me step on something with the ACA. So the ACA, it's got a really bad name. It's got a bad name with conservatives. It's got a bad name with the progressive movement. And the reason why is because it fell short of what it should have been. Am I correct about this?
Yes, absolutely.
Yeah. So that's all we're trying to do is really, and we could say, yeah, screw the ACA, it's done now. We're going straight forward to a single payer system, which is not government healthcare. Is that correct?
That is correct.
Right.
And I think the only people that have a right to even be worried about it all are the doctors and the owners of the hospitals and the CEOs. And if we do this the right way, they shouldn't really have too much of a problem either.
No, they should be okay. The CEO is probably gonna be okay, but no, I just want to say, and you just got to be careful sometimes, I think, with language, because with this, just like anything in the progressive movement, coalition building is so important. And so one thing I've learned as I've gotten involved in my local party structure and everything is, although we're progressives and we're shooting for the moon, not just shooting for the telephone lines, we're not incremental about our approach or anything like that. you really have to kind of like make sure that when you're calling for action, you're like, it's like when you provide feedback in a sandwich, a good, a bad, and a good. Like you have to really like honor that history because although the Affordable Care Act didn't go far enough for a lot of us, and of course something written by the insurance companies never would have, you have to be careful about stomping on it too much because a lot of the folks that are our allies in this, are very proud of that and they're very happy about that and they want it to go further, but it's just part of that little nuance of,
Right. Feel ya. That's like maybe we're playing different roles here, and that's maybe how we have to do it. Because I agree with you, but at the same time, when I'm out there talking to the people, certain people I talk to, they want to hear me say that. Then they're willing to listen to the single payer side a little more. So if everyone can pick up the double speak there, we're trying to get the truth to you in the most correct way we can without harming our, everybody else,
Yeah.
This is wonderful. This has been a really exciting one. Go ahead, Jake, Cindy.
Oh, the ACA did some very important things, and it's critical that we not lose those. What we're trying to do in Washington, we retain all of the pieces that the ACA has put in place, and then some. So I totally agree. The ACA fell short because it allowed the profit motive to stay in healthcare, essentially. In other words, it didn't move to essentially a single payer system, but it did put some very important provisions in place. And I think one thing that's critical is that most people, if you isolate those pieces and you ask them about those, they don't want to lose those. Okay. And that's across the board.
Fair enough. And we won't lose those, will we?
No, not at all.
So there we go. We're not going to lose the good stuff. We're just going to fix the part that did the most important part. And that brings us to this. What if, like the people that say, okay, why don't we just do Medicare for all and let some people opt out for their own private insurance? That was the ACA, correct?
Yeah.
And that will never work.
No, because it leaves the insurance model in place. And the other thing that it does is whenever you increase the risk pool by having everybody in it, it reduces costs across the board. So that's the big problem with the opt-out for private insurance, that it is basically unaffordable. That's the problem.
Yeah.
And also, and if you look at it, I mean, look right now, we have this opt-out with the ACA, and of course, like 23 million people, were left out of that and all that. But like, you have an opt-out, and then it means that you have to have this opportunity to opt in, and like with the Trump administration, like reducing the sign-up period and like the marketing for that whole program, reminding people to opt in, went down to like, so it just, we want to make sure that when we go for this, we do this moonshot, we get everybody in, everybody's in and nobody's opting out.
Everybody in, nobody out. Right.
Everybody in, nobody out. Right.
That's right.
But I feel like there really is bipartisan support like this, Adam, to your point. And like, if you just frame this the right way and, stop thinking about government and socialism and, and VA, if you just say, how, tell people, how would you like it if every single person you knew, your family members, your friends, your coworkers, your neighbors, the people at your church, your community, your club, whatever, had healthcare? Yeah.
Do you want to send your kids to school when they don't have the other kids in that classroom don't have healthcare?
Right.
You want to live in a country where 40 million people can't go to the doctor.
Mm-hmm.
I mean, I definitely don't. I could be selfish as hell about it and say, no, I really don't even care about those people, but I don't want to get sick. And that's how I'll get sick. Now, me personally, I care about everybody. I think every human deserves healthcare as a right, but that's my opinion. So this has been a great morning. We've done a lot. I've learned a lot. I'm so happy you both came on. I'm going to say a couple things here. So Valdez, I'm going to start something in Oregon, down here in Southern Oregon in Medford. I'm going to set up something to where we're going to do maybe weekly, maybe start once a month. I'm going to start going to the colleges. I'm going to start going door to door. We're going to start getting people to come and get involved, because that's what we need to do now. And we'll start calling our representatives. So that's going to be what I'm going to do here. And then Cindy, what we're going to do is we are going to start promoting. We need a fundraise. We need to get more people to do signatures. So we're going to go all over, get people out. I'm going to reach out to a bunch of the people out there that I know to go out to whole Washington to volunteer and to donate as much.
Thank you.
Even if you live in Missouri, donating $5 to a Washington healthcare plan sounds like, why would I do that? Because they are going to be the example. This is going to be the model that the whole country can follow.
Yes, we like to call ourselves the Saskatchewan of the United States, because that's how Canada's system started. Saskatchewan started it.
Okay, there you go. So that all we have to do is have something to follow. It'll make all the other states much easier to fall in line, and then we can all do it.
Adam, one thing I just want to say is, again, thank you for doing this show today and for doing what you do. And on this special Memorial Day show, I know a lot of people are thinking about people that they've lost or remembering. And I know a lot of those folks are not here anymore because they didn't have healthcare. And so it's just a great day to talk about this, have this conversation, and try to prevent that from happening in future Memorial Days. So anyway, thanks for having us on today.
Yes, yes, yes. And yes, everybody, respect to everybody out there who lost a family member for Memorial Day. Do what you have to do, and then we'll just move on in our lives. Let's go out. Let's barbecue. If it's raining, let's stay inside. Let's spend time with our kids and be praising that we're happy and healthy and we live in America. And let's make this country better. And one of the best ways we can do that is changing this massively corrupt, crazy healthcare system. So thank you, everybody. Thank you, Cindy Jacobs. Thank you, Valdez Bravo. We're going to have links below. We need to get people in Southern Oregon together so we can band a huge organization and a rising so we can do this. And Cindy, we're going to get people to volunteer and donate. All the links are going to be included in this live stream. Thank you, everybody, for tuning in. This is TCSN Live, Medicare for All Monday.